This is a different spectrum of toxicity. You know, this is not fever neutropenia.
It's a
right?
whole other ballpark.
Yeah.
So obviously autoimmune diseases are the ones that we now suddenly need to become very aware of. Also, if you're doing CTLA-4 inhibition plus PD-L1, PD-1 inhibition, we have to be very cognizant that they may actually be more likely to develop an autoimmunity. Like I think there was one grade 5 toxicity that was reported from a myasthenia gravis. I mean, when was the last time any of us who dealt with that in not a thymoma patient?
Right.
So certainly, you know, we've run the gamut. Colitis is usually the big issue. Fatigue, pneumonitis, as Dr. Herbst mentioned, is critical. And then we've had some more rare instances of paraneoplastic encephalitis in small cell patients who got ipilimumab. And so these are very, very different toxicities than what we're accustomed to in lung cancer.
And I think the take-home message for our listeners and the general population of oncologists is to be in tune. And that early intervention with particularly high-dose steroids and stuff like this is critical to kind of keep the toxicities at the grade 2, 3 level rather than the 4, 5 level in this population. But it takes almost retraining. Right?
It does, and your first instinct is to try to avoid the steroids. You have another reason for the problems. And many of these patients can have what's called pseudo-progression, about 10 to 20% of the time, where the tumor grows before it shrinks. So someone comes in, they're not doing quite so well. You think they have an infection. You also worry the steroids could have an effect on the person who's not yet responded. Once they've responded, the steroids usually don't have an effect later on. But if they haven't responded yet, but I would agree, you have to think about endocrinopathies and the need for steroids. We had one patient recently with severe hypophysitis, and you can actually see this on the X-ray. The pituitary is pretty much gone, and these patients really need their steroids. It affects their whole way they feel, and of course, if it gets even more, if they're under more stress, it could be really catastrophic.
I think the issue also with the colitis, I mean, all of us kind of have gotten a little jaded about diarrhea because of the EGFR TKI, so generally we just manage it. But in these cases with the immunotherapies, the diarrhea is actually a very serious thing. It's a totally different entity with the colitis. So we really have to be more on top of it, and you have to hold the drug and start the steroids very early on.
What advice do you give on this? You touched on the issue of pseudo-progression in the sense that cancers can look worse. I think we all factor in how the patient is doing clinically, but how much worsening is too much worsening? When do you switch to other therapies and those sorts of things? Heather, any?
I don't think you can draw a line in the sand. I mean, it's pretty individual. And it's also, and this is in the trial designs too, when we're doing the studies in the first line, the tolerance for any pseudo-progression is much different than when we're dealing with second, third, and fourth line. And it's something that involves a lot of discussions with the patient and a very careful assessment. I mean, if there's a sense that it's looking a little bigger and this patient's doing worse, we need to switch much sooner. Versus if they've already been through multiple lines of therapy, they're feeling okay, then it's okay to watch it a little bit and see if it is that versus if it's actually a progression. And normally it doesn't take more than one repeat scan to get a better sense of what's happening.
Tom, your experience in the squamous setting?
So I think you're always concerned about pseudoprogression. I think the critical thing is to talk to the patient when you start the therapy so that they understand. I think the first line setting you have a little bit more leeway because generally those patients are better performance status. And the third and fourth line, a little progression can lead to a lot of symptoms. And so I think you have to be really careful. You're trying to look at the scan and the person, come to a judgment. In the back of my mind, I always think, what's my plan B? And so I don't want to prematurely give up on something.
So Roy, I want to go back to something you said before. You said you hadn't seen these sorts of responses since the early days of EGFR TKIs. And of course there it was female adeno never smoker Asian populations that we're getting. Is there a clinical profile for the immunotherapies, or?
Not really. I think the thing that strikes me is it's really the general lung cancer patient. Now, of course, the never smoking patient is a very important lung cancer patient, but they still are the minority.
Right.
We have many former smokers. It's one of my other passions, smoking cessation. But many people who have stopped smoking still get the disease. These agents work in those smoking patients, and they work when you don't have a driver mutation. For all the sequencing we do at all of our centers, how often do we really find a driver that we can then say, here's the drug? Very rarely. So we're seeing activity in KRAS mutated patients. That's the major mutation in adeno for which we really have no therapy. And we're seeing activity in squamous patients and in smokers. Now, we don't want anyone to go smoke, but But I do think that there are many more mutations in smokers than non-smokers, and we are seeing that activity. So that's why there's so much hope that the realistic aspect of this is still unselected, so it's only 20%, and selected, you can get it to 30 or 35% maybe. We need to figure out, what about the other 70%? What else is going on in the microenvironment? Are there other checkpoints? I think the answer is probably yes. Are there other T regulatory cells and other components that need to be also inhibited? One thing we did with, this is some of the work in our research grants with David Rim and Li-Ping Shen, is we've looked not only at the PD-L1, but we've also looked at tumors to see, are there any T cells there? And interestingly, many times there are no T cells in the tumor. So it doesn't matter how much of this mechanism you have going on in the tumor microenvironment if you don't have the T cells getting there. So it might be we need to combine our therapies with interferon, interleukin, other things. So these are all things that are being studied.